that is close to 20 some percent improvement in the shift which is taking place. So this is of lot of interest to neurologists. So we thought that such a shift has never been reported with any compound after TPA. So let us compare with the only gold standard which is there, which is TPA, and we compared that. So in 1995, New England Journal of Medicine, they reported 0 to 1, 2 to 3, 4 to 5, and death. So we could, head-to-head comparison, we could do at 3, that is shift of modified ranking scale from 0 to 3, and that is coming out to be 9% with TPA. With sovateltide, it comes out to be 12%. And if we take 2 modified ranking scale 0 to 2, which is even better, the favorable outcome is coming to about 24-25% with sovateltide. So primary endpoint with modified ranking scale 0 to 2, it has met p-value 0.002. Another way to analyze is number needed to treat. That also is sovateltide 5. So to have the excellent outcome, you need 5 patients with sovateltide. With TPA, you need 10 patients with 3-hour window. And if you go 4.5-hour window, it jumps to 19. So in summary, it's a platform drug, although we are focused on acute cerebral ischemic stroke, and we have applied for marketing authorization. We got the minutes that IND committee has approved that this drug can be allowed to be manufactured and marketed in India. So now the formalities are going on, audits are happening. DCGI is conducting audits at clinical sites. So once all those are complete, manufacturing audit will take place, and after that, most likely by February, we should be having this drug in market in India. And we have also applied for the application for phase 3 directly in US is ready, and we are having good feedback from US FDA that we'll get straight phase 3 permission in US with the US FDA. So thank you very much, and I'll be happy to answer questions.
So congratulations, sir, for bringing this molecule to this level, and hope in future we'll be able to, some of us will be able to sort of be part of this molecule. Really great. Congratulations. Any question? 1 or 2 questions? Dr. Chauhan. Yeah.
Oh, I can. So I have a couple of questions. Very nice talk,
Thank you.
So my first question is, did you try the interaction of this drug with the TPA in vivo?
Can I have the, yeah.
So did you try the interaction of this drug with the TPA?
With TPA?
Yeah.
Yes. So as we indicated that there were 25% of the patients in the control group got TPA along with the drug, and 11% of the patients in sovateltide group got TPA along with the drug. And we have analyzed further. There is extensive due diligence going on with one of the pharma companies in Japan. So they wanted the timing between the 2 drugs. So TPA, in the patients who got TPA was the first drug, and sovateltide was the second drug which was given.
Okay. Thank you. And second question is, this all looks nice, but have you tried this in an embolic model of stroke where you can give it emboli, because most of the strokes are like embolic, right? 85% stroke. And then give a TPA to lyse the clot and give you a drug to see whether you have a longer outcome to prove in vivo that the TPA is not cutting this drug. And I also saw that in your listings, you only choose patients who were given TPA, but no one with a mechanical thrombectomy. So you do not take patients with a mechanical thrombectomy?
Mechanical thrombectomy we could have taken, but that would have confounded the results. Then the trial would have been completely different. Okay. So we are now doing patients, we have made the protocol for thrombectomy separately. I'll very strictly, this is another very important thing. When you are designing a clinical trial, you have to design, the key thing to design the clinical trial is to keep it clean and not confound too many factors. Otherwise, you will be getting results all over, and then you will have to do a 1,000-patient trial, which will take 10 years to do it. So that becomes more of an academic exercise. So we have to keep it a little bit, for example, when I was doing the trial on artificial blood, we kept blood loss only, not the fluid loss. So these are some things which have to be decided early on, that what is the protocol. And regulatory agencies also want a clean thing. They do not want things to be included. Later on, academic exercises can be done. And right now, for TPA, it is even easier for us because there is a trial which we are starting in Singapore where thrombectomy, because the catheter will be there in the artery, the thrombus is taken out by the stent, and we can inject the drug right in the arterial. So that trial will be starting soon.
Yeah, thank you. One more question. Yeah.
So, my name is Bharath from University of Wisconsin. So, phenomenal talk. So my only question is, if you need a clean data, you selected and excluded some patients, but the patients are not clean. They are come up with a lot of complications. So what is your next plan? How you are going to take this molecule to the complex patients?
Yeah, so TPA, already we know that only 5% or 6% of the patients are able to get. Even in the United States, only 10%. Japan is the only country where almost 50% of the patients are getting TPA because they are so efficient emergency management system. So the best part is that we decided to keep TPA patients in the trial, and we found that whether you give TPA or you don't give TPA, the results are, they are independently acting. TPA is to dissolve the clot. This is to protect the brain, regenerate the brain. So it is completely different. So it can be given, and 24-hour window also is very good, that even in remote areas, 24-hour window, a patient comes, they can be treated with something which is not available up till now.
Yeah, interesting. Thank you.
Thank you. Thank you very much.
Thank you. Thank you, sir, and thank you, everyone. Now I hand over to my colleague, Dr. Sharma, for further deliberation.
Yeah. And thank you, Professor Gulati. I think as a pharmacologist, always you are an inspiration for everyone because you are putting your molecules to the clinical stage and not to the market. So it's a great success. Congratulations for that. So now we are going to have the second speaker, Dr. Bharath Chelluboina from the University of Wisconsin-Madison, USA. And I'm happy to tell, like, he's from the University of Illinois, Chicago. He did his postdoc, and I think from the same place, also University of Illinois and Chicago, I also did my postdoc, actually. And Dr. Bharath published, actually, around 50 papers in the area of stroke, and now I think, without wasting much time, actually, I would like to invite Dr. Bharath to share his findings, actually, on a very nice topic, actually. I think is continuation to the ischemic stroke, impact of comorbidities in developing neurotherapeutics for ischemic stroke. And Dr. Bharath, please.
Thank you.
And I would appreciate, actually, if you can restrict 25 minutes of your talk and 5 minutes for discussion. Thank you very much.
Yeah, sure. I have a habit of finishing 10 minutes or 1 hour. Thank you. So thank you for your kind introduction. Good morning, everyone. It's my pleasure to be here today. And today I would like to talk about ischemic stroke, one of the subtype of stroke. So, stroke is a very common, most common leading cause of disability in the world. Today I want to share some of the factors that contribute to more disabling and more fatal strokes. So in particular, we and fellow researchers found that lot of comorbidities such as hypertension, diabetes, atherosclerosis, or renal dysfunction contribute to these disabling outcomes. And in our lab, we found that some molecules like extracellular matrix molecules, subclass, namely senescence, play a crucial role in connecting the organs between the periphery and brain, and it complicates the stroke pathogenesis. So my talk involves a brief introduction about the stroke and comorbidities and inter-organ mechanisms, and what are the challenges we are facing in developing or in studying stroke outcomes in presence of comorbid conditions. And the question comes whether developing a model is tough or identifying a common target is tough. And I want to link some of my recent findings with these things. So if you see, stroke is incredibly common. It is getting more common in younger population because of various life changes, particularly physical inability and atherosclerosis, high cholesterol, atrial fibrillation, and blood pressure. So here, since I'm talking about ischemic stroke, I stress more on atrial fibrillation rather than hypertension, because hypertension mostly leads to fatal strokes, hemorrhagic strokes, that I'm not going to talk about today. So ischemic stroke happens when there is a clot within the brain, but it is not necessary to form a clot within the brain. The clot forms somewhere in the periphery, and it travels all the way to the brain, and it blocks somewhere. So in clinical scenario, the symptoms vary between the men and women and depends upon the location of the blockage. For example, I'll show these are the common symptoms people suggest, especially American Heart suggests. If you have any of these symptoms, go to the hospital. And there is a chance, there is a time-based prognosis of the disease where you see the red color, the blockage happened, the tissue died. There is a green color, you are going to rescue the tissue by means of thrombolysis or thrombectomy if you go to the clinic within a 4.5 hour window in case of thrombolysis, or in case of thrombectomy, you can go up to 24 hours. But if you have a comorbidities, any of the comorbidities, it creates a pre-environment in the brain which compromises the neurovasculature, and it compromises various factors, including the transient attacks. Just like a heart attack, you don't even realize sometimes you get a stroke and the clot immediately dissolves. You don't even feel any neurological dysfunction. So in comorbid conditions, you don't really know whether the stroke is a first-time stroke or a recurrent stroke. So when there is a disability or comorbid conditions, the same like ischemic damage happens within the 10 minutes. In case of normal people, it happens in 3 hours. So here, in case of comorbid conditions, we have a narrow chance to rescue the tissue so that they get more disabled strokes and also more fatal strokes. And treating these patients is really, really tough. And I like the talk from Dr. Gulati, and where I interested more in exclusion criteria. So you recruited 700 patients, 760, and you excluded 600, where there is the patients with a lot of complex disorders. So my goal is how to treat a stroke if somebody come to the emergency room with a lot of comorbid conditions, and how to design the therapeutics. So we have a very well-established mechanisms in terms of stroke. We all know the ischemic stroke happens because of the rupture of the plaque somewhere in the periphery. It travels and blocks the brain, or inflammation or thrombosis within the brain, and which leads to gut dysbiosis, inflammation. Those are the common mechanisms recently demonstrated very well in humans and experimental stroke models. And if you don't treat properly, it ends up with some cognitive dysfunction and also chance of, again, recurrent fatal strokes. So if somebody have a comorbid conditions, the inflammation and sympathetic nervous system overflow starts just before the stroke. So your brain is already delicate to these changes. So the thrombosis happened in the comorbid conditions is more tough to break by the endogenous TPA. It needs more endogenous TPA, or you have to give more TPA. If you give more TPA, there is a chance of hemorrhagic bleeding within the brain. So these patients are not eligible for the frontline medications at the acute phase of the stroke. And also, here I want to, I don't want to touch with the inflammation because everybody knows about inflammation. I want to touch base with gut dysbiosis. So everybody knows stroke happens, stroke induces gut dysbiosis, but also comorbid conditions produce gut dysbiosis. But here, my focus is not about the gut dysbiosis happening because of the diseases, even not either because they involve in the pathogenesis. So here my worry is how, if you give a drug to these patients, how it is going to be activate or produce the therapeutic effect. Because a lot of antihypertensive agents or antidiabetic agents, their metabolism or activity depends upon the gut bacteria. Not only that, once they degrade into the product or bacterial products, if they have comorbid conditions, they can easily translocate into the brain and they cause undesirable side effects. So that is a very serious concern. Nobody looked at those things. And remaining like a gray matter and white matter is very common in kidney disease patients. It reduces the white matter and gray matter. So these are the complications. And also, you have a cell death mechanism which is very specific to the sex. Males have a different cell death mechanism, and females have a different sex like inflammatory mechanisms and cell death mechanisms. So altogether, it affects the diagnosis process. Whenever the patient comes to the clinic, most of them, they are not eligible to certain contrast agents if they have a renal dysfunction or a compromised kidney, or they are not eligible to take other contrast agents. And also, it interferes with the vascularization, either thrombectomy or thrombolysis. And also, most importantly, all the ischemic patients are going to survive for a relatively long period if you provide a proper post-stroke management. But in this case, even if you use a new generation oral anticoagulants or certain antihypertensives or a multi-drug therapy, they have a narrow opportunity to treat with the regular antihypertensive or regular medications. So here where my research comes. So I'm very particular about developing a preclinical model. Although we use a conventional techniques, the problem with the conventional technique in the stroke is there is a huge variability. If you show brain damage in one animal, and if you show behavior in other animal, or if you show physiology in other animal, there is no proper rationale to track down the prognosis. So here my animal design or experimental design is, I'll track a single animal from the zero. I induce the prognosis of comorbid conditions, whether it is a CKD or a diabetes or anything. Then I induce a stroke, and I'll track the same animal up to the survival and end point. So we use various techniques, you name it, whatever the techniques we use for human clinical trials, we use in the lab. So we use ultraset and like a microspect with Neurolite, which is a clinical tracer for the CBF. And my study design is long-term. So we use various MRI techniques with the contrast agent to determine the BBB disruption and brain damage. And we also do some regular behavioral motor function tests, trotter rod and beam walk. And we do Morris water maze, and we do survival things. So this is a plan. And so these are the things published recently by our group in stroke. So here we identified the aging and time of treatment play a crucial role. Although I don't want to discuss all the things, I'll show that there are few things we have to observe in the cresal things. The young brain, if you induce a stroke ischemia for 60 minutes, it produces the damage which is equivalent to if you induce a stroke in an age group in 30 minutes. That means basically it is producing a 50% more in case of age groups. And also if you treat acutely, it gives protection. At the same drug, if you treat a delayed time point, it is not going to work. So those are things we have to consider. So meaning that therapies in the stroke, especially in the different age groups and male and female, are time dependent. So this is an interesting and very latest technology. We used nanostring, genomic spatial profiling for proteins. So what is happening in the comorbid conditions? So comorbid condition itself produce some proteomic changes in the brain. So what are the blue color shown here? The proteins, we profiled 57 proteins, and we identified some proteins induced after only comorbid condition in the normal brain without any stroke. Then we induced a stroke, and those molecules are further induced in a comorbid condition plus stroke group when compared to the stroke group. Then we compared what are the common targets. Is there any common targets in this study? We identified several molecules. The molecules of my interest is the cleaved caspase-3, a well-known cell death marker, and fibronectin. So fibronectin is a very good molecule to interact with the different organs and cells. So we want to pursue like what happens, what causes these things. So fibronectin, we know from the literature that certain molecules like tenascin C activates or induce the mechanisms through the fibronectin, and also like other inflammatory mechanisms. So I will introduce the tenascin C. So which is a very good protein in the developing brain. It helps to develop the organs, and it disappears as soon as the brain development is over. But in adults, if it induces again, that indicates that person is having some problem in the brain, or overall he has some disease. This is like a condition of inflammatory marker. It's a biomarker. So it's currently using as a biomarker for several diseases. Not only biomarker, this level, CSF levels of tenascin C is an indicator. We can predict whether the hemorrhagic stroke patient is going to die or survive based on the tenascin C levels. Not only that, this is a time-dependent activity. It also have a very good activity at the delayed phase of the stroke. In case of hemorrhagic stroke, the problem is if you have a more tenascin C in the delayed phase, there is a chance of wound healing followed by the scar formation. So you all know if the scar formed in the brain, then it produces the convulsions. And again, the post-stroke convulsions is a detrimental factor. In most of the stroke patients, they are going to die because of the seizures. Post-stroke seizure is a detrimental thing. So not only this, it also participates in the thrombotic plaque stability. If like a healthy person have a stable plaque, he's not going to get any blockade. But once there is a high levels of tenascin C, it destabilizes the plaque, and that detaches from the blood vessel. It travels somewhere and blocks somewhere in the brain or some other parts of the body. And also we have a direct role on the TPA. And also there is a disparity in using a knockouts as well as like inhibition of the tenascin C. Because knockout, since this tenascin C is very good for the brain development and organ development, knockouts are not an option for here. So we decided to block this tenascin C by using a siRNA technique, and also we are developing some inhibitors. And we came to know that tenascin C upregulates after strokes for several, like 42 days. And also stroke pathology peaks at the third day of stroke. So we want to study what happens to the mechanisms within the 1 day and 3 day, and also outcomes up to 1 month and survival up to 180 days. And we identified this tenascin C induces immediately after stroke. We tested up to as soon as 3 hours after reperfusion. So we tested the efficiency as well as the in vivo delivery of the siRNA. So the spectral imaging shows there is no differences in the blood flow dynamics whenever you after administering the siRNA. And also we checked whether it reached the brain or periphery. So we decided we injected the fluorescent dye along with the siRNA to the retroorbital sinus, and it entered into the brain. Then we tested the protein efficiency, and it knocked down sufficient amount of tenascin C after stroke. Then we tested for the infiltrated cells as well as the apoptosis. The siRNA administration at the 5 minutes of reperfusion reduced the neutrophil infiltration and also the apoptosis. There is an interesting mechanism. This tenascin C attracts the inflammatory cells from the periphery by means of a chemotaxic entry, and it's promoted into the brain. And also like a cell death mechanisms. And also it works closely with the myeloperoxidase, and it recruits the cells to the brain. Then next, we are interested to see, is it because of the chemotaxic entry alone, or is there any brain disruption or BBB disruption after stroke, and what tenascin C is doing for the brain disruption? And I'm very interested in non-invasive imaging. I don't go for conventional techniques. That's what I want to say to all the students. So look outside the boundary. So I induced a stroke, and I treated with the tenascin C, and I injected a gadolinium, which is a very, very famous contrast in the clinic. It don't enter into the intact brain. If it enter into the brain, that indicates the BBB disruption. And we identified there is a huge uptake of the gadolinium into the untreated group when compared to the treated group. And we further confirmed with several proteins by testing for the tight junction proteins. And next, we want to see what happening to the brain damage. We did a T2 MRI, and we identified the brain damage reduced with the tenacity knockdown. And we also do like a T2 star and DWI images to see iron content that indicates the hemorrhagic transformation in the brain. And we also see neurodegeneration by using amyloid tracers, by using PET scan. We have all the facilities. And also, like these are the direct effects because there is no changes in the fluid dynamics. And next, we tested the motor and cognitive functions by using a water maze and this rotor rod and beam walk. We identified a significant good recovery after a stroke and treatment. Then we identified what kind of mechanisms playing a role, and we identified there is a we screened only few like well-known pro-inflammatory cytokines, and we identified some sex differences here, but I don't want to talk here, but I will talk in the next slide. So here, it is very interesting that males showed iron beta very high, almost like 24-fold, and females showed only 6, because like young females have more protection after stroke when compared to the males. So then, we know like more in-depth mechanisms. We know tenacity activate different functional groups. Then we want to see one of the endogenous ligand for tenacity is TLR4, toll-like receptor 4, and we profiled all the signaling, total signaling of TLR, toll-like receptors, and we identified few molecules changed in a differential manner in the male and female. So if you identify TLR4, it reduced with a tenacity knockdown in both males and females. If you take the TLR3, it reduced only in females, meaning that TLR4 males are following the mid-88 pathway, and TLR3 females, they are following mid-88 independent pathway. So this is really interesting. This prompted us to check what happens exactly in the toll-like receptor 4 knockout mice. Then we purchased recently mice, and we induced the tenacity siRNA, and we identified it further reduced. We know TLR4 is a protective after stroke, but it further reduced with the tenacity knockdown, meaning that tenacity is partially acting through the TLR4, and also it has its own mechanisms with the other functional domains. Then, if you want to take any drug to the clinic, we know there are several like limitations to siRNAs and adenovirus and lentiviral. So recently we screened for the druggable targets. So we identified tenacity TLR4 interactive sites and also tenacity TLR4 independent site, and we are currently screening some 10 structural molecules. So we purchased from the Sigma, and once we get an inhibitor, we want to check in the animals, and we want to start a clinical trials. So this is a story of tenacity in young mice, male and female. Now we are working on various comorbid conditions to see whether those complex mechanisms I discussed earlier are playing a role here. So this is about my story, and these are the conclusions. So testing post-stroke therapeutics in all the comorbid conditions is really complex, and also it produces less conclusive results if you use a conventional technique. And also common targets like tenacity are the best way to go, and non-invasive imagings give a very good rigorous information about the disease ongoing pathogenesis. You can test the magnitude of the damage. And with this, I'll thank my team, and my Professor Vemuganti is one of the mentor for me, and also all my team. And I'm happy that I have my own funding, and also I borrow funds from my mentor, Professor Vemuganti. So basically, we have a very rich lab. We can do whatever the imaging we want, and we can do like plenty of stuff. Thank you. Thank you for your kind attention. I'm happy to take any questions.
Thank you, Dr. Bharath, for, I think, finishing within the time limit, actually. Thank you very much, actually. I think one of the issues always comes with the stroke is the translational failure, because most of the drugs which have been discovered, they could not go to the market. And that we can see, actually, maybe in future, the success of Dr. Gulati drug, how it's going to perform. I would like to know, because when we do a lot of experimental studies, always we look into the S.A.S guidelines, actually. In your study, how you're following those S.A.S guidelines for these studies?
So my study is, we always follow state criteria, but earlier we used to do, I have all the struggles of failure when I worked with the diabetic mice and hypertensive mice and other mice.